So I want to talk to you today about reimagining how to personalize treatment and care and trials so that we can continuously learn and improve so that everyone will have a better option tomorrow than they have today. Those three words, you have cancer, strike fear into a woman's heart. So what do we do to change that? Many years ago, I started a program called the I-SPY Trials to try and figure out how we can bring personalized care into the clinic and into clinical trials. Clinical trials are tomorrow's treatments today. Every new drug, every new device comes from a clinical trial, but we tend to want to test these as if everyone has the same thing instead of really personalizing treatment. That's the goal, that's the idea. That's what everyone wants, but we don't do it very well. And our vision for this whole program was to try and think about how we could make new, better, and more personalized treatments available faster when patients need them most. And by better, we not only mean long-term survival, but we also mean less toxicity. By personalized, we mean matching the treatment to the biology and to people's preferences. And by faster, we mean using early endpoints and continuous learning. So how did this come to pass? 30 years ago, a young physicist named Nola Hilton came to me with the sequences and the device for what became breast MRI, and said, how would you use this? And I said, I want to look at the people who show up with the big bad cancers. And it turns out they all didn't look the same. And then when we started to treat them first, they didn't respond the same. So I thought, okay, how can it be that the standard of care is, here's the regimen, and this is what you get? That just makes no sense. And all the new drugs are tested first in the metastatic setting, where we measure the increment of improvement by months of additional survival instead of cure. And where it took 17 years for a new drug to get its way into the clinic. Part of the issue is that when people come into the clinic with a bad cancer or a big cancer, the standard treatment is surgery. But when you do that, you take away the biomarker. We have no idea how they're going to respond. And the truth of the matter is, if you are going to die of your disease, you're not going to die because it's in your breast. You're going to die because it gets outside the breast. I am a surgeon. I would love to be the hero, but that is not the best way to use my craft. The best way to use the craft is to say, hold on, let's figure out what kind of biology you have, and let's start testing the new drugs, and let's start figuring out how to improve them, improve the treatments, and see if you respond. And then if you respond, great. And I'll show you why that's so important. And if you don't, we are forearmed and can maybe try something else. So the idea is to start with, for these molecularly high-risk cancers, you want to start with the treatment first. Systemic treatment first, because that's what's likely to kill you. Surgery to find out how much disease is left. And why does that matter? This is an example from one of our when we actually showed the pembrolizumab, the immuno-oncology agent, could make this go away when we combined it with Taxol. And why does that matter? Because this is a Kaplan-Meier plot on the left. That blue line, so that's event-free survival, percent chance of survival on the y-axis, and time on the right axis. You see that flat line, 92% survival if the tumor goes away, compared to 67% at 3 years. You want to be on the blue line. So we built a platform, not where every time you want to test a new drug, you build a new trial. That'd be like every time you play a soccer game, you tear down the stadium after you finish the game. But that's basically what we do. You laugh, okay? So I said, no, we're going to have a platform. And companies will put their drugs into the same trial. Took us a while, but we did it. I always say I was successful because no one thought I would be successful, so no one bothered to get in my way. But, so the idea is, so we have what I consider now what I wanted to build at the beginning. So we opened this trial in 2010 after we spent a decade getting everyone to do things the same way. And what we discovered was, now what we have is, we have 3 blocks of treatment. novel agents that have no standard chemotherapy. Then if you don't succeed or you don't have the best response, we've developed new ways of classifying your tumors, response predictive subtypes, where we can now assign the best treatment for your subtype, or if there isn't one, to test something better, in combination with standard chemo, and then following rescue therapy if that doesn't work. Adriamycin, the dreaded chemo that we want to avoid from 1950, right? And so we started this in 2022, and I am excited to say in 2 years, from first patient in to first presentation at ESMO and publication, we showed that a combination of therapies could get 55% of people with an immune subtype to a complete response with no chemotherapy, no standard chemotherapy, and 90% without AC. That's progress. But we aren't done. We aren't done. We have a long way to go. And these are the most aggressive tumors. The average age is 46. I would have to say that 85% of these are not found at screening. We'll get to that in a moment. So the concept of how to study things, we have a platform design, 45 sites across the country. We have response monitoring with serial MRIs, biological targeting, treatment redirection, so if you do better, you can stop. If you not, we can move on to the next thing. Treatment sparing, and compare treatment strategies. Okay, now let's go to the complete other side of the coin. Screening finds lots of things. Ductal carcinoma in situ is a pre-cancerous lesion, okay? This is from an editorial I wrote with Scott Egner about Gleason-3 prostate cancer and DCIS. The problem is that not all of these are going to progress. And for young women, half of them get mastectomies, some of them bilateral. And everyone's getting breast conservation, most with radiation. But what if 70% of them didn't need that? This is largely a diagnosis of screening. 3% used to get DCIS, now 25% are diagnosed with DCIS. And at diagnosis, a woman who was destined for a bilateral mastectomy had this kind of white out of her breast. I put her on tamoxifen for 3 months. It's one of my studies. Nothing there. 5 years later, she is fine. No surgery, no nothing. So that prompted us to start another platform trial called Recast DCIS, which we just opened up. And this is important because everyone thinks about screening. All due respect to the cardiologist, we're not so good at mammography screening because cancers are different. Some grow very fast, like tumor type D, and you can see if you're getting serial screens, it doesn't work very well if your cancer is growing very fast. So if you find a mass, you better go in and make sure you tell your doctor about it. Those tumor type Cs probably benefit the most from screening, but we make maybe a 2 to 4% difference in mortality. For something we spend $10 to $20 billion on in aggregate a year, we ought to demand better. Okay, but those things, tumor A and B, they may never come to clinical attention and we overtreat them. 75% of the biopsies we do are benign. This is a problem. Screening has to reflect our new understanding of breast cancer. And I am 100% with you because what do we need to do? Better risk assessment. If one size does not fit all for treatment, why in the world are we screening everyone as if they have the same cancer starting at age 40? That makes me insane. Okay. And every celebrity who gets cancer, oh, go out and get your mammogram, that's going to solve the problem. That will not solve the problem. What will solve the problem is new approaches and new ways of thinking about things. So we started the Wisdom Study, another platform study called Women Informed to Screen Depending on Measures of Risk. We wanted to compare personalized screening to annual screening, because it turns out it's actually much more cost effective. You can assign treatments better. We look at your genetic risk, not the genes that you inherit. There are 3% of them can confer an 85% risk. Okay, and we also look at polygenic risk, many genetic genes that you can take that together, we can find the people at low risk and high risk and start to figure out not just who's at risk for cancer, but who's at risk for what type of cancer, so that we can start to do different things and think about prevention. I'm tired of seeing those numbers grow up. Why are we at 300,000? We should demand to have it down at 100 or 150,000. And we discovered, the way we do genetic testing is if you have a family history. But guess what? In Wisdom 1.0, 65% of the people with mutations did not have family history. That is not the way to determine it. We've discovered that we can do this on a population basis, No one's going to have a meltdown. There's no terrible thing. It's a piece of information, right? But we want to find those people not at 40, but at 30. Genetic testing, the way we use it, it's less than the cost of a mammogram for us. Go to the website, thewisdomstudy.org, and you can find it. There you are. That's all you need. But we are really excited. We actually have 15,000 people now enrolled. So we have touched many people. We are trying to democratize access. You don't have to have any particular healthcare anywhere. Wisdomstudy.org, we have someone from every state. We are doing, in the top 2.5% of people at risk, we are calling and counseling and trying to help people do the things that will reduce their risk. We have now almost 90,000 people registered. We put 4,000 people on last month. Good and bad. We've completed over 30,000 genetic tests, shown that this is absolutely feasible. And I am happy to say 25% of our women now are minority-based. But it wasn't always that way, actually. We started out after 2 years at 1.7%. And we have worked really hard to change that, because you can't have trials that don't represent the population. And the whole issue of higher black breast cancer mortality has got to be addressed, because that actually helps them and it helps us as well to understand that. The whole idea is trying to implement subtype-specific screening, try and use mammographic AI to improve. Everybody with dense breast does not need supplemental screening. Maybe 10% do. We need to figure out how to get that stuff implemented. And then we have to model the benefits. When we first rolled this out, I had this great idea, because it's actually cost-effective to start with that risk assessment first with genetic testing. But unfortunately, it's hard to move the insurance companies. So I just have to raise the money for the genetic tests. That's the way it goes. So I'm just going to close by saying I think the greatest problem is that regulators, physicians, and especially insurance companies do not like change or risk. But patients want something better, more effective and less toxic, and we have to aspire to better. And I am very proud of building culture around all of these trials that allows us to take the risks that we need. This is my favorite quote from Elias Zerhouni, and it says, the greatest risk in science is to stop taking risk. And if we want innovation to thrive in the future, we have to foster a culture across our trials and across clinical care that prizes the habits of thinking outside the box. And if we want to ever get to a higher level, we have to be willing to let go of the rung to which we're clinging. So, thank you.